Thank you for your interest in Minding the Baby home visiting. The purpose of this webinar is to provide some basic information about the MTB home visiting model and implementation. For additional details about the clinical model or the MTB National Office, please visit our website at www.mtb.yale.edu. A brief animated video on the MTB approach is also available on our YouTube channel, and it will play at the conclusion of this PowerPoint presentation. This informational webinar will begin with a brief introduction to MTB home visiting and research outcomes, followed by an overview of replication requirements and implementation considerations, including whether MTB is a good fit for a given agency or organization. We'll then address some frequently asked questions and conclude with next steps for those interested in pursuing MTB implementation. Minding the Baby is one of 19 home visiting models currently designated as evidence-based by the U.S. Department of Health and Human Services via Home V review, and thus MTB is eligible for McV funds, as well as state funds in Connecticut. MTB is an intensive and preventive home visitation intervention developed for at-risk young parents and their first babies. A 27-month intervention, MTB begins prenatally during the late second or early third trimester of pregnancy and extends through the child's second birthday. An interdisciplinary team, including a nurse and a social worker or a similarly trained mental health clinician, rotate to provide weekly home visits to MTB families beginning prenatally through the child's first birthday, then every other week in the child's second year. A treatment manual and quick reference guide are provided to clinicians along with intensive introductory training and ongoing clinical and supervisory consultation. That said, MTB service delivery is highly flexible and responsive to families' individual needs, and this is supported through the training and consultation required to implement MTB. MTB was developed specifically for complex families with high levels of early adversity and toxic stress. Core aims include building foundations for wellness and social-emotional competence from the ground up and providing an intensive level of support for positive health, attachment, and mental health outcomes, intervening before negative patterns become entrenched. MTB's interdisciplinary health and mental health approach is unique and includes both clinicians and supervisors in each discipline. Highly trained practitioners address the health and mental health needs of both parent and child, working collaboratively to address families' multiple needs. MTB nurses provide critical health information, routinely assess health and wellness, and triage with medical systems, while the mental health clinicians provide assessments and therapies, as well as case management and support. MTB also specifically promotes reflective parenting, which has been linked to behavioral, attachment, and health outcomes. MTB clinicians are explicitly trained and equipped to support families who are coping with the effects of chronic poverty, toxic stress, complex trauma, and adverse childhood experiences. MTB was originally offered within the framework of a randomized controlled trial in New Haven, Connecticut, beginning in 2002. And MTB continues to be a part of evaluation and longitudinal research efforts at Yale University. MTB grew out of a collaboration among the Yale School of Nursing, the Yale Child Study Center, and 2 local federally qualified health centers. MTB was first replicated in England and Scotland, beginning in 2011, and then in Miami-Dade County, Florida, in 2015. In 2016, the MTB National Service Office was formed at Yale, and a new international implementation began in Denmark. In 2017, MTB services began to be offered in Fairfield County, Connecticut, through a collaboration with 2 agencies in Norwalk and Stamford. In 2019, a new collaboration began with Yale New Haven Health Services to offer MTB as part of the Family Home Visiting Partnership of New Haven, funded by the Connecticut Office of Early Childhood. Study data have shown a range of improved health and relationship outcomes in MTB families when compared to control families receiving standard prenatal and postnatal care. Combined documented impacts on health, attachment, and child mental health outcomes are evident in these research findings, all of which were significant. Lower rates of obesity and higher rates of normal weight in MTB toddlers. Higher rates of on-time pediatric immunization. Lower rates of rapid subsequent childbearing. Higher levels of reflective parenting. Higher rates of secure attachment. Lower rates of disorganized attachment. Less disrupted interactions between teen mothers and their children, and a trend toward lower rates of child protection referrals. Additionally, follow-up data showed significantly lower rates of maternally reported externalizing problems in MTB children ages 1 to 3. In a longer-term follow-up study with 4 to 9-year-olds, preliminary data analyses suggest that MTB parents are more supportive and more reflective, and that their children have fewer internalizing, externalizing, and total problem behaviors. There are a number of core elements of the MTB home visiting model that make the intervention distinct from other home visiting programs. While there is some room for adaptation, it is important that several key elements are part of implementation, in part to ensure fidelity to the evidence-based model, as well as to use the Minding the Baby trademarked name. Some of these essential elements include the following. Service delivery by an interdisciplinary master's level or equivalent clinical team offering both physical and mental health services. Prioritization of first-time parents and prenatal enrollment. A focus on the development of the clinician-parent relationship as the primary agent of change. Flexibility in service delivery based on the MTB treatment manual and training, but matched to family needs and suited to families of diversity with respect to economic, social, and racial or ethnic backgrounds. An evaluation component with agreed upon data submitted to the MTB National Office at regular intervals, and the exclusion of mothers with serious substance use histories. This is due to the additional complex needs related to recovery and treatment. As such, we recommend that parents with substance abuse histories be referred to a treatment-focused alternative. Additional essential elements are outlined in the MTB Replication Planning Guide, which is available by request. MTB model developers Drs. Arietta Slade and Lois Sadler, along with MTB National Office staff, offer a comprehensive set of training programs available to organizations seeking either to implement or supplement similar reflective parenting interventions, or to replicate the MTB-HV service delivery model. Replication requirements include a multi-phase training and consultation program, typically lasting 30 to 36 months, and beginning with startup consultation and introductory training for all MTB staff. The first 2 phases typically span 3 to 4 months as collaboration gets underway and clinical teams are hired and trained. Following the initial multi-day training, and once the clinicians begin seeing families, monthly consultation sessions begin with MTB National Office staff. This consultation will be described more fully in the next slide. An optional train the trainer component may also begin during the first or second year of implementation. This optional component involves the participation of qualified MTB supervisors in an intensive training program to become MTB trainers. MTB trainers gain experience in the MTB-HV model in order to address specific staffing and supervisory issues and become qualified to provide ongoing training for MTB teams. Approximately 10 to 15 months into service delivery, Site visits are conducted in conjunction with the ongoing consultation, distance learning, and fidelity monitoring activities. As mentioned, ongoing regular consultation sessions with MTB National Office staff are a requirement for MTB home visiting implementation. These sessions begin once the clinicians begin seeing families, and they are scheduled approximately monthly throughout the first 3 years of implementation. There are 4 types of consultation sessions: administrative consultation for program coordinators, interdisciplinary clinical consultation for both clinicians and supervisors, discipline-specific consultation for each clinician, and supervisory consultation for supervisors in both disciplines. In addition to ongoing regular consultation, quarterly distance learning sessions begin within 3 to 6 months of the start of service delivery to supplement the initial training and support teams as they move forward in the intervention process. Additional details about the phases of replication, consultation requirements, and related logistics are included in the MTB Replication Planning Guide, which is available by request. The cost of providing MTB services varies depending on region and agency, mainly due to variance in salary, benefit, and overhead costs. For a full year of service delivery at the intended dosing level in the US, the per family cost has ranged from an average of approximately $10,000 to $13,200 per family per year. This includes the cost of pre-birth visits to the expectant mother, but does not include the costs of training and consultation. These costs also vary based on the number of teams and sites involved in implementation, and they are finalized on a per-site basis via contract negotiation. Training and consultation contracts are typically entered into for a 12 to 36-month period. The first year of implementation involves the highest cost due to the intense multi-day introductory training, as well as startup consultation and collaboration. These costs, however, may be shared across agencies if more than one site or agency embarks upon implementation at the same time and their teams can be trained together. These costs also decrease over time, provided there is staff retention, in that trained staff require less consultation over time and with experience implementing the model. Additional details are again provided in the MTB Replication Planning Guide, and a breakdown of typical training and consultation costs is also available by request. There are a number of issues to consider prior to making the decision to implement MTB home visiting. This process should begin with a thorough review of the MTB clinical model for appropriateness to the agency, community, and client population. As discussed in the MTB Replication Planning Guide, it is also important to examine current programming, perhaps conduct a needs assessment, and talk to other providers in the community and key staff within your agency to gauge acceptance of the MTB key elements and overall approach to home visiting. MTB National Office staff are available to discuss any questions you may have and explore goodness of fit between your organization and the MTB home visiting model. While consulting the MTB Replication Planning Guide and discussing agency fit, some helpful questions to consider include the following. Do the primary aims of the model and the general MTB approach align with the key values of your organization or agency? Are MTB's essential elements doable within the context of your organization and target population? Are you likely to have access to the families who will be most well served by MTB? Is there a referral system in place that will work well with MTB recruitment? Are MTB outcomes in line with those that are a priority within your organization and community? Does your agency currently employ clinical and supervisory staff who meet MTB requirements? And if not, is this workable within your agency context? Do you have the infrastructure and administrative capacity necessary to administer and supervise MTB implementation? Are you able to budget fully to enable practitioners to deliver MTB? This includes attending training, participating in ongoing consultation, undertaking weekly home visits, and participating in related meetings, in addition to providing supervision for home visitors and covering the costs of training and consultation. Some frequently asked questions about MTB implementation are listed here, and brief answers will be provided shortly. We welcome the opportunity to explore these or other questions further and upon review of the Replication Planning Guide. So first, we are often asked, how many families are served by an MTB team? A full-time caseload for a single home visiting team typically ranges between 22 and 24 families by the second year of implementation. This results in around 10 to 12 home visits per week for each clinician. Caseloads build slowly over time, with fewer families in the first year, and additional families recruited as the initial families transition from weekly visits to every other week. There are a number of variables involved in determining caseload size for a given implementing agency or location. Are any adaptations permitted? Certain adaptations or modifications are possible based on community needs or agency requirements, but only upon discussion and in agreement with the model developers. Is guidance provided around clinician and supervisor qualifications and requirements? Yes, this is addressed briefly in the Replication Planning Guide and in more detail during startup consultation, as well as in the MTB Operations Manual provided to all implementing agencies. MTB National Office staff also consult in the recruitment, interview, and hiring processes. We provide sample interview questions along with job descriptions and competencies for home visitors and supervisors. Are there any technology requirements? A smartphone and/or tablet should be provided to home visitors for use in the field. Aside from this, access to the web for consultation via Zoom video conferencing is necessary, along with the ability to enter data into a web-based form from either the field or an office location. It is also helpful for the teams to be able to access our password-protected web portal for implementing agencies, which includes links to Google Docs. Are there evaluation or fidelity requirements? Yes, implementing agencies are required to collect specific data for evaluation and fidelity purposes and submit certain data to the MTB National Office. These data and related processes are discussed and agreed upon during the startup phase of implementation, with an emphasis on reducing client and clinician burden to every extent possible. Where can I get more information? As mentioned, the MTB Replication Planning Guide is available by request, along with an executive summary and fact sheet. To request these materials, submit questions not covered in this webinar, or schedule a call to discuss the possibility of pursuing MTB implementation, please send an email to mindingthebaby@yale.edu. What are the next steps to pursue implementation? Upon review of the planning materials, discussion with the model developers takes place via phone, video conference, or in person. Once the decision to proceed with implementation has been made, a realistic timeline and budget are agreed upon with the MTB National Office at Yale, and an implementation agreement is signed. Our team is more than happy to collaborate on grant writing and proposal development as part of this process. Contractual needs can then be pursued as applicable, and once in place, initial meetings or calls are scheduled with the model developers to plan for hiring, evaluation, and general implementation. Before we conclude, we would like to acknowledge the generous funders who have made MTB possible. Our thanks goes out to these supporters, as well as to the many champions, collaborators, and MTB staff who have moved this work forward over the last 18 years. Again, for additional information, please visit our website at www.mtb.yale.edu or send an email to mindingthebaby@yale.edu. We'll now conclude this webinar with a brief animated video on the MTB approach. Thank you.
Parents are often overwhelmed by the demands of child rearing. The minding the baby approach helps them meet the challenge by being more reflective. Generally speaking, we get along better with the people around us when we try to understand them. That is especially true for parents. So when a baby cries, whether the parent should rock, feed, or put the baby down for a nap depends on why they are crying. Do they need comfort? Are they hungry? Are they tired and fussy? Asking these simple questions requires the parent to imagine what the baby might need or feel or want, and to test various possibilities. We call this being reflective, trying to understand the feelings, needs, and thoughts that cause behavior. Ideally, we do this all the time because we are curious and interested in what's going on in the minds of those dear to us. However, many parents find this difficult. Feelings and thoughts can be scary or disruptive, and so parents want to avoid them. Instead, they focus on stopping or correcting the behavior without wondering what the baby is telling them. With the MTB approach, parents feel calm enough and safe enough to ask why, to think about what their child or themselves are feeling, so they can respond in a way that will help the child feel better and help them feel better too.